Hello and welcome to Investigator Insights targeting c-Met receptor as a strategy for treating cancer. So these Investigator Insights programs are designed to give us an opportunity to sit down with clinical investigators who are intimately involved in all of the clinical trials and research with novel emerging agents in a particular area. And we're going to break this program down into three parts. Initially, talking about c-Met and its ligand and just what its function is in the normal cell and how it becomes involved in malignancy. We'll go on in the second part and talk about the early clinical trials, phase 1 and phase 2 trials, some of which are completed, some ongoing, and then move on in section 3 to talk about the future and ongoing phase 3 trials and where our experts see c-Met targeted agents moving into our therapeutic platforms. So joining me for this session is Dr. Johanna Bendel and Dr. David Spiegel, both from the Sarah Cannon Research Institute. So welcome to both of you. Thanks so much for coming in today.
Yeah, thanks for having us.
Well, this c-Met is very interesting. I mean, I think most community oncologists are very familiar with receptor tyrosine kinases like EGFR and HER2 and VEGFR, but c-Met has sort of been sneaking up on us. So, David, tell us a little bit of an overview about the c-Met receptor and its ligand and what its role is in the normal cell.
Well, yeah, I think it has been complicated because there does seem to be this traffic jam of signaling pathways in oncology, and what's important now maybe didn't seem to be so important yesterday. It's true that EGFR, the whole EGFR family, HER2, EGFR, have been kind of the big stories, I think, certainly in breast cancer and lung cancer, among other cancers. The MET receptor pathway has actually been well described now for many years. I think what's changed recently has been the development of new drugs that target this pathway. We know that this receptor is present in a number of epithelial tumors, including non-small cell lung cancer, actually small cell lung cancer. I know Johanna will talk in a moment about the GI malignancies. We know this is common in head and neck cancers. This is probably a pathway that's not been exploited or investigated enough, but certainly, as you've alluded to, a number of drugs are in development to start to target this pathway. We know that this receptor, the c-Met receptor, is important in tumorigenesis. We know that activation of this receptor can occur many ways. It can be stimulated, by its ligand, which is known as HGF, or sometimes referred to as scatter factor or hepatocyte growth factor. It's the ligand to this receptor, and we know that if you have overproduction of this ligand, that can lead to overstimulation of this pathway. We know that the receptor itself can be altered or amplified because of genomic alterations. We know that there rarely can be even mutations in this receptor that lead to its activation. So there are many ways that this receptor or this pathway can be activated. And like most receptor kinase pathways, it's the downstream effects that lead to all the hallmarks of oncogenesis. So the ability to spread within the microenvironment throughout the systemic circulation. Actually, there's been links to MET activation and angiogenesis. So trying to turn this pathway off, like I talk to patients, turning this switch off could be important in causing tumors to die.
Right. So we know, Johanna, in EGFR, it seems to be the mutation that is the key, especially in certain non-small cell lung cancers. And KRAS is another mutation that is important. But in c-Met, as David said, mutation doesn't seem to be the key oncogenic factor. It's more gene amplification or protein overexpression. How common is this seen in GI malignancies, and what sort of effect does this have? Does this lead to constitutive activation of the receptor? And is there much in the way of crosstalk between c-Met and a number of the other receptors we've already mentioned?
Well, what's really interesting about c-Met is it can be activated, as you were saying, in multiple different ways, and you can tell that in different tumor types, it tends to be activated in specific ways in different tumor types. And so you can get this increase or constitutive activation of the kinase within c-Met, so that means the inner part of the receptor just keeps sending signals no matter what happens. And those signals are sent down the PI3 kinase pathway, down the RAS-RAF-MEK pathway, so we know that it activates certain pathways within the cell that we're now becoming familiar with in the treatment of cancers. We've also seen increased receptor expression across the cell surface. We've also seen what's interesting about the c-Met is that there seems to be a very key play between c-Met activation on the tumor cell and the microenvironment of the tumor itself. And so we've talked a lot, and you might hear a lot about this stromal tumor interaction. And what we're starting to focus on a lot now within cancer therapy is how the tumor reacts with its microenvironment. And we think that if we can block that interaction, we might be able to have a better anti-tumor effect. So the MET pathway is one of these key pathways that's involved, because HGF, or hepatocyte growth factor, the ligand, is what activates c-Met. But it's interesting because to activate HGF, you actually have to cleave it. So you have to break it in two. And so the molecule that cleaves HGF to make it activated, to then activate the receptor, is produced in the liver and then increased by the tumor microenvironment. And so that activation, and this is one of the ways that tumors can have overactivation of c-Met, is to produce a lot of hepatocyte growth factor as well as produce the factor that cleaves HGF to activate it. And so I think that you've got multiple mechanisms of activation. You've got a lot of crosstalk within the tumor and its microenvironment. And then on the cell surface itself, c-Met seems to be a co-activator or co-receptor for the EGFR family. And then within VEGF, not necessarily VEGF on the tumor cells, but there seems to be, as David was alluding to, an angiogenesis play where increased levels of HGF correspond with increased levels of VEGF and back and forth. And so it seems to key up angiogenesis within the tumor.
So there's a loop that they keep turning each other on. So is HGF binding always required for c-Met activation, or can c-Met be activated like through interaction with EGFR or other receptor tyrosine kinases?
The only ligand that we know of for c-Met is actually HGF. And so when you form that heterodimer, you do need HGF to be able to activate the MET receptor. But then you can form the heterodimer with, for instance, the EGF receptor and cause increased signaling down the pathway.
So let me just move to David for a second. So in non-small cell lung cancer, what is the typical situation for c-Met? Is it amplification or overexpression or interaction with other receptor tyrosine kinases that seems to play the greatest oncogenic role in lung cancer?
I think it's fair to say that these data are still emerging. I mean, we're just now doing formal prospective studies trying to understand these expression rates, these mutation rates, amplification rates. I think historically we know that mutations are quite rare. So in non-small cell lung cancer, mutations are going to be well below 2%. Certainly, I think some series suggest well below 1% of patients will have mutated tumors. Although I tell you this, and we recently have discovered mutations in patients we've seen at our center. Expression by immunohistochemistry is a different story, and of course that depends on how you score that. Is it any expression like the story with EGFR, or do you have to have a certain level of expression, so-called 3+ or 2+, and a certain proportion of cells? So I think it depends how you define that. In some studies, I'm sure we're going to get into this, in some studies that high expression is thought to be in at least half of patients with non-small cell lung cancer. Wow. In other studies, if you're only looking at 1+ expression, it might be the majority of patients with non-small cell lung cancer. When you look at amplification by FISH, that number is lower than IHC but higher than mutation. Some estimates put that around 10%. It might be a little bit lower, and I think in more modern series suggesting maybe closer to 5%. I think what's clear is that this is not present in every patient. We're not yet sure the best measure of this receptor or this this altered pathway for patients. So that's certainly a subject of ongoing investigation. And then we don't yet know what the cutoff is. What is it that turns this into a targetable pathway for that particular patient? Do you have to have a certain mutation? Do you have to have a certain degree of amplification, or do you have to have a certain degree of expression for this drug to work well in that patient? And
what turns it into the actual driver for the
yeah, I think certainly a lot of lessons have been learned from trastuzumab, Herceptin, and HER2. With the 1, 2+, 3+ scoring system and amplification by FISH, which is now the standard. Is that going to be a similar story here? It doesn't look so far that it's going to be as easy as mutation testing for EGFR. That will identify MET mutations in 10 to 15% of patients with non-small cell lung cancer, and they'll just go on this pill, and that'll bind to the ATP binding pocket, and that'll shut down the receptor. It doesn't seem to be such a simple story there.
Very good. And how about in GI malignancies? Is it more amplification or overexpression? And with the hepatocyte growth factor being the ligand, what goes on in hepatocellular carcinoma? Is this going to be a real target for c-MET-directed therapies?
We're even a little bit behind non-small cell lung cancer within GI cancers, trying to figure out, does staining make a difference? We've been using IHC because we're following the track of the lung cancer, where it does appear that overexpression and as witnessed by IHC seems to be correlated with impact of MET inhibitors in treating cancer. Now, hepatocyte growth factor indeed has become much more interesting. We saw results from a randomized phase 2 study recently of tivantinib, which is a c-MET inhibitor. It's a tyrosine kinase inhibitor. We're not quite sure that it's purely a c-MET inhibitor, but they tested it in patients with second-line hepatocellular cancer, randomizing them to tivantinib versus best supportive care and placebo. And we saw an improvement in time to progression as well as overall survival within this small phase 2 study. And it seems to be even more pronounced in the patients that were designated c-MET high by immunohistochemistry.
So these were overexpressors.
Correct.
Very good. All right. Well, we'll move on now, and we'll bring a halt to this session, and then we'll go on and talk about some of the early phase 1, phase 2 clinical trials and what the clinical data has shown so far. So thanks for this session, and we will be back to you shortly and talk more about the actual clinical data that is emerging with c-MET receptor targeted therapy. Thanks so much.